We are joined by the Director of the All India Institute of Medical Sciences, Dr. Guleria. Dr. Guleria, irrespective of the merits of the test, should Delhi be relying more on RT-PCR tests than the rapid antigen test?
So in my mind, we need to rely on both of these tests because we need to understand the pros and cons of each of the tests. The gold standard, like you said, is the RT-PCR test, which can be done in a lab, or also done by now what is known as the Gene Expert or the TrueNat, which is a test which is also using the RT-PCR, but is using a machine which is usually tests for tuberculosis and drug-resistant tuberculosis.
Yeah.
But that turnover of that machine is slow because the number of samples it can do at a given point in time is low. Now the rapid antigen test, and this was validated when it first came at AIIMS itself before it was rolled out. We looked at it in our OPD area where we had our staff coming and other people coming. And what we found was that it is a highly sensitive test. That is, if you are positive by the rapid antigen test, you are definitely are infected with COVID-19. But this test, it's a simple test. It gives you a result in 15 minutes. It's a point of care test. You can do it right there. You don't have to go to a lab. But the disadvantage is that if your viral load is low, then this test does not multiply the virus as the RT-PCR does. So if your viral load is low, then since it doesn't multiply the virus as the other test does, you may have a false negative test. Therefore, what we found was that in all those individuals who were symptomatic, who had classical features to suggest that they could have COVID-19 infection, the positivity was close to 70 to 80%. However, 30% or so were those who were turned out to be negative by this test, but were positive by RT-PCR.
Sure.
So what it basically means is that your first line, in case you need to really screen people quickly in the community who have fever and COVID-like symptoms, should be the rapid antigen test, because you can isolate them quickly. And one of the things that was happening was that it was taking a long time to get the RT-PCR result. And if you get it after even 3-4 days, that means that individual is actually spreading the infection for 3-4 days.
Sure. And
therefore you're losing precious time.
But Dr. Guleria, is there not therefore a serious concern that given the high rates of false negatives which actually emerge from rapid antigen tests, particularly in asymptomatic patients, there is a worry that these individuals who actually have COVID have not been given the RT-PCR test. They are out there in the open. They have very mild elements of the illness themselves, but because they're potentially spreading it, somebody else with, say, comorbidities can pick it up, can suffer much more.
Correct. So I would say that if you look at the guidelines, and the guidelines are very clear, that if you have a negative RT-PCR, your rapid antigen test, and there is a strong suspicion that you may have COVID-19 because of your symptoms, or you are a close contact, then you should get the RT-PCR test done if you are negative. Because a negative rapid antigen test does not rule out active disease. The advantages are two of the rapid antigen kit. One is that it gives you a result immediately. And even if you have some positivities, it decreases the load on the lab which does the RT-PCR. And therefore, you could do a larger number of tests in the lab as per RT-PCR. But it's very important that people who are doing the test at the ground understand the utility of this test and don't misuse it, because if you start doing it if you say that if you are negative by rapid antigen test and you are symptomatic, you don't have COVID-19, that is a wrong interpretation of the test. And thereby, you are right that then you could lead to spread of the infection, development of clusters, and also infect the high-risk population, causing serious illness.
But Doctor, just one more question on Delhi. Given the discrepancy in the numbers that we are seeing in the positivity rate, these are ICMR numbers, between what we are seeing in Delhi in RT-PCR and rapid antigen tests, there's a huge discrepancy between the two. Could that be because of the standard of the kit in Delhi as far as rapid antigen tests are concerned? Because that's also a factor. Where have the kits come from? Earlier on, several months back, we spoke about kits procured from China. They were spread out, they did not work, and they were discredited. Now we have this discrepancy in Delhi at a time when the government is saying that, look, maybe we are doing well in the fight against COVID. So how do we account for this discrepancy?
So as far as the kit is concerned, there's currently one company which is supplying it. There are others which are also going for it. And all batches are actually now validated by AIIMS because of the previous experience with the antibody kit. Also, these are kits which come from South Korea. And now they are being manufactured in India only. And there is a plant which is approved by the DCGI, which is in Manesar. And therefore, now they are made in India by the company, which is a South Korean company. And therefore, there is a lot of quality check which is done because of past experience. So I'm quite sure that the kits are of good value. The only issue is that people who are doing the test have to be trained properly, first, how to do it in terms of taking a proper nasal swab. And secondly, that you have to be able to understand the limitations of the test. And like I said in the beginning, that if your test is negative, it does not rule out COVID-19 infection. And if you have a high index of suspicion, you must get an RT-PCR test done.
Right. All right. And doctor, tomorrow is an important day. Tomorrow is when we actually begin human trials of the vaccine being developed in India. Tell us a little bit about that, because you've been part of the process which has said that, okay, fine, go ahead with the testing. How extensive will this testing be?
So we are now starting phase 1 of the trial for the vaccine. These are human trials. So what was done in the past few days was the data was looked at extensively as far as the animal data was concerned to make sure that the vaccine is safe. The first concern is that when you're giving it to humans and you're giving it to healthy volunteers, you must have a good backup data to show that the trials in animals showed good safety profile. That was looked at by the ethics committee, and they satisfied themselves, all the members satisfied themselves that whatever animal data is there suggests that the vaccine is safe. And now we can move to the next phase, that is the human trials. And the first phase will be to actually give it to a group of healthy volunteers to make sure that there are no side effects or no signals to suggest any side effects of the vaccine that we're giving.
Right.
And then we will move to looking at the efficacy, that the vaccine produces good immunogenicity and the immune response is good. And then the next phase is to see how it behaves in a real life situation and how effective it is in the elderly, in children, and in high risk groups like people who have comorbidities in terms of protecting them.